Good evening. Shock is obviously extremely important for surgeons for many reasons. The two most important are one is trauma, second is septic shock, and third one is hypovolemic shock. So the hypovolemic shock may happen either due to trauma or due to bleeding during surgery or prolonged surgery, or patients who um, have surgical problems like intestinal obstruction where there is pancreatitis, where there is sequestration of fluid, and that causes shock. So we do deal with shock on a regular basis. So we need to know, identify the early warning signs of shock and then aggressively manage it, and also identify the source and cause for the shock and then address that. So I think the very important class for all of us as surgeons, and it's good to repeat it. Samir will now take over. Over to you, Samir.
Yes, sir. Hello. So am I audible, sir?
Yeah, yeah. Carry on.
Yes. Good evening, everyone. Today we'll be dealing with reading about shock. Uh, the definition, shock is defined as a global tissue hypoperfusion state leading to a cellular hypoxia and dysfunction. Further, based on the etiology, it can be divided into distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock. So why is shock important to us? As we know that our body is dynamic and constant attention to fluid loss therapy is essential. The task of managing blood volume is one of the most challenging burdens we face as surgeons. Bleeding, sepsis, neurological disturbances, and organ dysfunction can affect the patients, and the regulation of blood volume is highly time dependent. Only after prior resuscitation, we can go ahead with definitive management of the disease and avoid permanent organ dysfunction or death. So, coming to the history of shock, in 1743, the term shock was first used by French treatise Henri Francois, who described the shock as a collision impact in battlefield wounds. And later, Guthrie, he published the term in 1815, defining the shock as physiological instability. And further, IV fluid therapy was first, the clear description was given by Harman in 1830, where he used IV fluid therapy in cholera patients. And further, Shaw and SC injected salt solutions in cholera patients, which were further used in patients with shock. In World War One era, Cannon's theory of toxins and adrenal gland function came into view. Um, and the definition of shock was first given by Gross in 1872, who described it as the manifestation of rude, unhinging machinery of life. Then Cryle incorporated the blood pressure when there was the first manual sphygmomanometer into patient's examination, and he proposed that the fall of blood pressure is the core reason of symptoms of shock, and he helped to incorporate blood pressure into clinical medicine. And further, Blalock's series of experiment who theorized the extracellular fluid, intercellular fluid, and water recruitment, and thereby the concept of third space loss was derived. And Blalock gave the various causes of shock as to as this hematogenic, neurogenic, vasogenic, cardiogenic, and large volume loss as the reasons. So now going to the classification of shock, as you can see in the picture, there is either volume loss or the change in output. Volume can either be there is either volume loss in shock or shift in shock. We'll first deal with the hypovolemic shock. Hypovolemic shock is usually acute, and the clinical features is as simple as acute bleeding from the vessels. The etiology can be either gastrointestinal bleeding, aortic aneurysm, uterine atony, vascular erosion in the ear, nose, and throat. The loss can either be hemorrhagic, traumatic hemorrhagic, hypovolemic, or traumatic hypovolemic. The difference between hemorrhagic and traumatic hemorrhagic shock is that in traumatic hemorrhagic, there is an additional component of soft tissue damage. Due to the degree of soft tissue damage, there is inflammation which is widespread and it aggravates the shock. In hypovolemic shock, the loss of body fluids, either from the external or the internal loss, which is either due to diarrhea, uncompensated renal loss, diabetes insipidus, diabetic coma, or even in plasma loss in ileus and liver cirrhosis occurs. And in traumatic hypovolemic shock, it is usually due to the large surface burn area, large surface burns, where there is loss of plasma, causing the coagulation cascade activation, and thereby there will be impairment in micro and macro circulation, causing severe coagulopathy. So, hypovolemic shock in total can be summarized as there will be drop in cardiac preload, further causing the reduced macro and micro circulation, and thereby causing negative tissue metabolism and inflammatory reactions. Then going to the distributive shock. Uh,
Sir, Niranjan sir has joined, sir.
Good evening, Niranjan.
Good evening, sir.
Carry on.
yes, sir. So in the distributive shock, we'll first see the septic shock. Uh, So as we can see in the image depicted here, uh, septic shock will have two major components, which is the endothelial dysfunction and the activation of innate immune response. Due to the endothelial dysfunction, either due to this infections, there will be release of cytokines, reactive oxygen species, and activation of coagulation cascade. This will lead to microvascular occlusion, and also the activation of innate immune response will cause the activation of macrophages, neutrophils, dendritic cells, and T cells, causing vascular instability. Both of this microvascular occlusion and vascular instability are interlinked. This will cause further coagulopathy, the capillary leak causing edema, tissue hypoxia, and fever. This is the dysregulated host response, which we define as sepsis. In sepsis, further, when the condition aggravates, it will cause cardiovascular derangement in the form of decreased mean arterial pressure. There will be respiratory issue causing decreased FiO2 and PaO2, and neurological disturbances causing decreased consciousness in the patients, and oliguria, as in the renal system, and hepatic and coagulopathy causing platelet dysfunction and coagulopathy. This is termed as the organ dysfunction. Organ dysfunction with due to the dysregulated host response due to the infection is the septic shock, which will further lead to multiple organ failure. Then the anaphylactic type of distributic shock. Anaphylactic type is usually the Ig mediated shock response. This is massive. This is caused due to massive histamine mediated shift of fluid from the extravascular space. The triggers are usually due to food products, insect venoms, and drugs. And uh, the release of extravascular space will cause the similar the clinical features as the septic shock. Then going to the neurogenic shock, as we can see here, neurogenic shock can be described as a two-point mechanism. At the time of injury, due to the primary lesion, which is mostly due to spinal cord injury, there will be inflammation, and there will be this reversible process whereby there will be activation of microglia and neutrophils, causing the release of cytokines, IL-6, TNF alpha, and interleukin 1 beta. This will cause the microvascular hypoperfusion, metabolic acidosis, and mitochondrial dysfunction with the release of cytochrome C. And there will be anomalous cellular deposition in the neural tissue, which is observed by the Wallerian degeneration, as we see over here. Further, in the systemic level, because the nucleus ambiguous, the ventrolateral nucleus in the medulla, and the nucleus tractus alterus in the uh, these three will manage the heart rate and blood pressure in our body. Due to the dysregulation, the heart rate and blood pressure are impaired, and the direct injury to the circulation, which occurs due to the compression of brain stem, usually due to basilar artery thrombosis or even due to drugs, will cause dysregulation of circulatory system. Altered circulatory centers in the medulla oblongata due to fear, stress, or pain will cause dysregulated vagal reflexes. And further, the sustained trauma, which is above the spine, which will cause the paraplegia in the patients. So about majority of neurogenic shock are due to spinal cord injury, and rarely it can be caused by the epileptic seizures, meningitis. Neurogenic shock is characterized by a sudden drop of systolic arterial pressure below 100 of mercury, and a heart rate of less than 60 per minute, with decreased consciousness in the patient, and there will be loss of spinal reflux. Further, the splanchnic venous system and the skeletal musculature capacity will rise, causing and while the systemic venous pressure will drop markedly. About 20% is the mortality in neurogenic shock according to studies. Then we go to
Just,
the
just a minute,
yes,
Samir,
sir.
just a minute.
Yes, sir.
Ainas, what is the, I think he has described the neurogenic shock very well. But what is the final common pathway in neurogenic shock?
Uh, so, like, it is because of the injuries, are like,
No, injury is the cause. But
yes,
what is
sir.
the final common pathway? You don't know?
So, like, no, sir, like, I'm not sure, sir, that this is what I thought of.
There is nothing called like, no, like, yes. It is no or
No,
yes.
sir, no, sir.
Okay. Praveen,
Sir, yes, sir.
what is the final common pathway in spinal shock?
Sir, autonomic nervous system will be damaged.
Good. I think it is the autonomic dysfunction or autonomic dysregulation. So that is what is the final common pathway. All that what Samir described finally works through autonomic system, sympathetic and parasympathetic. Okay. Carry on, Samir.
Yes, sir. Now going to the obstructive shock. As we can see over here, The obstructive shock pathophysiology can be described according to the location. It is usually due to the mechanical intra or extravascular factors which reduce the blood flow to the great vessels and also the decreased cardiac outflow. As we can see here, it is either due to the tension pneumothorax, cardiac tamponade, or pulmonary embolism. Common to all of these obstructive states is the rapid, massive drop in cardiac output and blood pressure. The symptoms of obstructive pathway are actually non-specific and they can mimic mm, cardiogenic shock. But due to the compensatory autonomic response, there will be tachycardia, tachypnea, oliguria, and altered consciousness. And then the final will be the final will be the cardiogenic shock. The cardiogenic shock is primarily a disorder of cardiac function, um, and this is due to the critical reduction of heart's pumping capacity caused by the diastolic or systolic dysfunction and reduced ejection fraction or impaired ventricular filling. Cardiogenic shock is defined as systolic arterial pressure less than 90 mm of mercury or mean arterial pressure of 30 millimeters of mercury below the baseline value or the cardiac index. Cardiac index is defined as the cardiac output by the divided by the body surface area. If the cardiac index is less than 1.8 liter per minute per meter square, without any mechanical or pharmacological support, it is defined as cardiogenic shock. So the cardiogenic shock, as we can see in the image over here, it can be either due to the myocardial pump failure, brady or tachyarrhythmias, or the mechanical failure. In the pump failure, it is either it is mostly due to the acute coronary syndrome, wherein there will be the a reduction of pump function. Other causes of this pump failure can be due to cardiomyopathy, myocarditis, and drug-induced toxicity, and even blunt trauma to the heart. The mechanical failure of heart is due to acute or chronic valvular diseases. Um, and also there can be intracavitary structures impeding flow to the heart, either due to thrombi or tumors. The cardiogenic shock, the main symptoms are clinical features are agitation, disturbed consciousness, cool extremities, and oliguria. Death in the cardiogenic shock is usually due to hemodynamic instability, multiple organ failure, and systemic inflammation. Then coming to the core physiology of shock. Shock occurs at three anatomical areas as we saw in the cardiovascular system. The first level will be at the heart, where the abnormalities can either be extrinsic, like we have in the pneumothorax, cardiac tamponade, or cardiac tamponade, or it can be intrinsic, either due to acute coronary syndrome, myocardial infarction, cardiac contusion, or even cardiac failure. Then the second level of shock can occur at the level of large or medium vessels, in which there can be hemorrhage and loss of blood volume. And the last level will occur at the small vessels, capillaries, which is either what we saw in the neurologic shock, anaphylactic shock, and sepsis. This will lead to the vasodilation and maldistribution of blood leading to the shock. According to ATLS, these were the classes of shock according to ATLS, where wherein the class 3 is moderate and class 4 is severe. The problem of ATLS classification is that they were arbitrarily generated, and patients do not exhibit all the changes which are described in the table. For example, in the extremities of age, when we see geriatric patients, the geriatric patient group are less equipped to compensate for blood loss, and they will actually show signs of higher level of shock at a lower blood loss, because there will be cardiac compensation and low fluid reserve. uh, in contradictory in the pediatric population, because they are able to compensate with large volume of blood loss. They will exhibit features like tachycardia at a higher blood loss, and until this tachycardia is being recorded, after this there will be a steep loss of volume, which is catastrophic. So the problems of ATLS class is that in trauma patients, it is difficult to access the shock. Now, further going to the arterial versus venous bleed. As we know, the arterial bleed will have uh, a early tachycardia and then a relative bradycardia. The relative bradycardia in patients with arterial bleed is defined as the heart rate below 60, below 100 beats per minute, while a systolic blood pressure is maintained by the body at about 90 millimeters of mercury. This is actually protective to our body until a extent. Uh, then, when the bradycardia reaches below 60 beats per minute, the patients are usually moribund. It has been found in the studies that the patients who are bleeding and a heart rate of about 60 to 90 have a higher survival rate in comparison to patients who are actually tachycardic. So the arterial bleed can either be due to a transected artery or a lacerated artery. A transected artery will have spasm, and it will actually, there will be thrombose of the bleed, and it will stop. But in a lacerated artery, due to the spasm, the hole can actually enlarge, and there will be a lot of blood loss. And arterial system if there is a arterial bleed and the blood pressure has been monitored, there will be a early low blood pressure. And in because of the arterial bleed, the manifestation of ischemia will be late. So the measurement of lactate or base deficit will yield normal results. In contrast, if we see in the venous bleed is actually slow, and the patients will have time to compensate the venous bleed. So the venous or capillary bleed is slow, and to manifest into ischemia, there will be a massive blood loss before the hypotension is actually seen clinically. Um, so this is the difference between the both bleed. Um, Monitoring the shock.
Just a minute,
Yes,
Samir.
sir. Yes, sir.
Any questions so far? Nitya? Hello, Nitya is not there.
No, sir, I'm there from there.
Any,
No questions. No questions, sir.
anybody else?
No,
Nikita,
sir.
Very silent. Any questions?
No, no, sir.
Okay, carry on, Samir.
Yes, sir.
Niranjan, any clarifications or questions so far?
No, no, sir, nothing, sir.
Okay, carry on, Samir.
Yes, sir. So, coming to the monitoring of shock physiology, the clinical indicators and nuances, it is uh, generally we are told that hemoglobin is a predictor of blood loss. But this is actually true in patients who have received a lot of crystalloids, and if there is a rapid drop in the hemoglobin, it usually shows that there is a massive blood loss. High or normal hemoglobin actually cannot rule out significant bleeding. But if there is a low hemoglobin level, uh, which has occurred rapidly, it will reflect severe blood loss. So, as such, hemoglobin is not a good indicator. And also hypotension, which has been set to a standard value of 90 millimeters of mercury, is actually patient dependent, and this level is actually variable and it depends on age. For example, in geriatric population, the normal vital signs, normal blood pressure, can actually we can miss the occult hypoperfusion which has occurred in the patient. And if the lactate and base deficits are measured at at that point of time, they will yield better results. So these are the nuances of our standard
So I
points.
think you're right in whatever most of what you said. Only thing about hemoglobin is that you have monitor at regular intervals, and then initially there will be compensatory, fluid so because of the crystalloids and other things. You may get a spurious value, but if you monitor it regularly, especially if you are managing patients after trauma or after post-operative bleed in a conservative manner, and if there is a significant drop in blood pressure when you are repeated monitoring, then it becomes significant. Otherwise, hemoglobin may be spurious.
Yes, sir.
Okay, carry on.
Sir. Then going to the indicators, shock index is defined as the heart rate divided by the systolic blood pressure. It has been showed by studies that it is a better marker of assessing the severity of shock than the heart rate and the blood pressure alone. And it has utility in trauma patients and also in patients with hemorrhagic shock and other forms of shock which we have discussed earlier. But shock index, because it did not have a value of this diastolic pressure, so modified shock index was derived, and modified shock index is defined as the heart rate divided by the mean arterial pressure. Modified shock index is a better indicator than the shock index for mortality rate, mortality prediction. And if as we see, the if the modified shock index is low, it tells that it is a hyperdynamic state of circulation. And if the modified shock index is high, it denotes that there is a hypodynamic circulation. But as we
Just,
see,
just a just a minute, Nikita. He Samir said about hyperdynamic and hypodynamic shock. Can you
Yes.
give us an example for hyperdynamic shock? Anyone else? Tanya?
Anaphylactic.
Sir,
Sir,
is it like
Anaphylactic shock may not be this one, because in anaphylactic shock what happens is the the histamine and other, IgE related, they will be released very quickly, which causes significant vasoconstriction. So there will be shock because of vasoconstriction. So the hyperdynamic shock initially with sepsis, when you have significant sepsis, initially there will be bounding pulse. Patient will be flushed, and the blood pressure, in fact, will be high or normal or high. And along with it, you will have tachycardia. So as the shock progresses, then you will have splanchnic vasoconstriction, tissue edema, and peripheral vasoconstriction, and then you get the other manifestation which will then become hypodynamic. So septic shock initially may be hyperdynamic. So that is one thing you have to remember.
Yes, sir.
And sometimes even the spinal shock can also be like that because of the autonomic system dysregulation. So there may be hyperactivity of the adrenaline and noradrenaline causing bounding pulse, and then the noradrenaline takes sort of effect. Then you get vasoconstriction, and then you will get hypotension. So mainly for surgeons, you should remember hyperdynamic circulation in early shock, so early sepsis. Carry on, Samir.
Yes, sir. So, uh, beside the index, adding variables such as Glasgow's coma scale, lactate, hemoglobin, gender, and the age will yield much better results. And hence, there is no alternative to clinical judgment, experience, and the decisions which experienced back doctors do. Hence, the modified shock index or shock index has not been widely accepted as a indicators of shock. Now coming to the lactate and base deficit. Lactate has been thought to be the trusted marker for injury and ischemia. Uh, Lactate is a byproduct of anaerobic metabolism and is routinely thought that it is a waste product and it is completely unfavorable. But modern evidence suggests that lactate is actually an active metabolite, and it moves between the cells, tissue, and organs, where it is actually oxidized as fuel, and seems to be a shuttle. Lactate seems to be a shuttle for energy, which is the lactate shuttle. And lactate is now being studied as a pseudo hormone, which regulates the redox state in our body, wherein there will be it affects the ratio of NAD and NADH ratio, and it is released into the systemic circulation, and wherein it is taken by the distal organs, and there is also evidence that lactate has a role in wound regeneration, increased collagen deposition, and neovascularization. Lactate causes vasodilation and catecholamine release, and it also stimulates fat and carbohydrate oxidation, which will finally keep fuel. Now coming to the base deficit. Base deficit is defined as the measure of
Just a minute, Samir.
Yes, sir.
Ainas, what is the normal lactate level? What is abnormal lactate level? And what is used currently along with lactate to, especially for surgeons? Ainas, are you there?
Yes, sir. Yes, sir. Yes, sir. So, the normal lactate, sir, I'm
You
not,
don't know.
sir, like it varies between venous and arterial, sir, like 4.5 to like 20, sir. In venous and arterial should be like between 5 to 15, sir, milligram per deciliter, sir. Like,
I think it is usually, I think it is usually measured in millimoles per liter. Anybody else wants to tell me the correct value?
So that will be in 0.5 to 1.5, sir. Like millimoles.
Yeah. So, 1 to 1.5 millimoles is normal. Preferably 1 millimole per liter per deciliter.
Normal levels is up to 2, sir. Think.
Two is abnormal.
Greater than
So
to hyper.
if you have two previous, hello, somebody, there is some disturbance. Previously, 4 was considered as abnormal. Now, as Niranjan says, 2 is the, if
2 to
anything
4
above
they
2,
say is mildly elevated. 4 to 6 I think is moderate, and then 6 and above is significant or
but,
of concern.
but the moment you get to 2, you have to start acting. Otherwise, it will relentlessly go up and then you will lose the patient. So, be aware, 2 is the value. And then, of course, what Niranjan said is right, but anything above 2, you have to be very worried. Because what you have to remember is, by the time it gets to 2, lot of the body's own, the compensatory mechanisms would have come into place. So, and despite all of these compensatory mechanism, if lactate is rising, then it indicates that there is a problem. Okay. And where is the lactate, sort of excreted? Anybody? Ainas, Tanya?
Liver
Ah,
metabolism, sir, and
yeah. Liver, how much? What percentage?
sir, up 70% around, sir, 60 to 70%
Correct.
clearance.
60%. And then what else?
Sir, then renal excretion, sir.
Renal excretion, how much?
Sir, the remaining 30%,
30.
sir.
30%. The remaining is in by other organs, which is about to 10%. So 60, 30, and 10. So in patients who have, for example, if let us say the lactate level has gone up and the patient has liver dysfunction and the lactate level has not come down, it may not necessarily indicate that the sepsis is ongoing. It is just that the patient has got liver dysfunction, especially in patients who have alcoholic and other liver disease. And similarly, renal patients who have renal failure, the excretion of lactate is impaired. So, even though maybe sepsis is coming under control, because the kidney is not effectively able to get rid of the lactate or the patient has not been dialyzed, then the lactate level continues to be high. So you have to be wary of these things. So this is where, when what Niranjan said about the levels of 2, 2 to 4, 4 to 6, and above, say 6 to 8 will come into play. So you have to interpret lactate as I think Samir has very beautifully said a lot of things about lactate. Lactate was considered as a villain, but nowadays it is now considered that it is much more useful. But you should interpret lactate levels along with the general condition of the patient and other organ dysfunction. Okay, carry on, Samir.
Yes, sir. So the base deficit is defined as the measurement of number of millimoles of base required to correct the pH of 1 liter of whole blood to 7.4. The normal values range from -2 to +2 milliequivalents per liter. Uh, most of the studies show that base deficit, once elevated, it is a indication of ongoing shock. But there should be some adjustment of base deficit because of the crystalloids which we give. Chlorides seems to alter the base deficit, and in a renal failure patient, the normally if the base deficit is 10 milliequivalent per liter, it is a indication of shock. But in renal failure patient, the value is at 6. Milliequivalents per liter, which is associated with poor outcome. So chloride correlation and this renal failure correlation is needed for the interpretation of base deficit. Now for the compensatory mechanism, there is the blood flow which is diverted from the less critical areas to the more critical tissues. There is a decrease in the intravascular volume and increase in sympathetic activity. The role of renin-angiotensin system is that the juxtaglomerular apparatus in the kidney in response to the vasoconstriction which occurs in shock and a decrease in blood flow will cause the release of enzyme renin, which will lead to the generation of angiotensinogen angiotensin 1. The angiotensin convertase enzyme located on the pulmonary arteries will then convert the angiotensin 1 to angiotensin 2, which will stimulate the sympathetic drive at the adrenal medulla. The adrenal medulla will then release the norepinephrine and epinephrine, which will then act on the myocardium and vascular smooth muscles. This will cause the increase in heart rate, contractility, peripheral vascular resistance, which in total will cause the increase in blood pressure. Then the blood will be shunted from skin, skeletal muscle, and splanchnic circulation, which are less needed at the time, and to more critical organs such as brain, liver, and kidneys. Then there is the role of aldosterone, which is the mineralocorticoid, uh, which causes recovery of sodium and excretion of potassium, thereby uh, 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 preserving the water. And antidiuretic hormone, which is released from the posterior pituitary, causes retention of free water at the level of kidney. And at the capillary level, there will be fall in hydrostatic.
Samir,
Yes,
hey,
sir.
Nikita, where does this one ADH act and where does aldosterone act? Don't know?
Sir, ADH actually acts on kidney, sir.
No, kidney is fine. I'm not asking kidney. All of them act on kidney only. Homework, or if anyone
Yes.
can, anyone can give the answer correctly.
Sir, ADH acts on collecting ducts and
Correct.
DCLs,
And
distal convoluted tubules.
this one, aldosterone.
Aldosterone only on the distal
No,
tubule, sir.
no, aldosterone on the loop of Henle. So I think that is the. So I think that is why potassium is excreted and sodium is retained. That is the action of aldosterone, and ADH will reduce the urine output by reducing the loss of water in the distal in the collecting ducts and distal convoluted tubule. Okay, carry on, Samir.
Yes, sir. Then coming to the lethal triad, in the state of shock, there is inadequate perfusion causing acidosis, and there is decreased ATP production causing hypothermia. Hypothermia then causes worsening of coagulation system due to enzyme inefficiency. Coagulopathy will again further increase the bleed, and there will be hypoperfusion, which adds to the vicious cycle of lethal triad, and this will lead to the cycle of death. So coming to each components, acidosis is a response to bleed and hypoperfusion, and the acidosis which we deal in shock is mainly the lactic acidosis. But acidosis as a state, the body responds better to acidic state than the alkaline state, and tissues actually get preserved more better in the acidic state, and there will be more oxygen delivery in the acidic state. But correction of acidic state, if it is done rapidly, has consequences of respiratory acidosis. As a physician views the alkaline environment, uh, they believe that the enzymes work better in alkaline environment, and coagulopathy will be better managed in if the body is in alkaline environment, and the rapid and infusion of bicarbonate, which is usually the correction modality in acidosis, causes a increase in blood pressure. Treating the cause, which is blood loss correction or the goal-directed hypoventilation, is much more vital, and proper use of bicarbonate should be done rather than just treating the pH, is what studies suggest. Yes,
Just a
sir.
minute. Yeah, good. I think what you said is right. Nikita, what is the exception to what he said? That acidosis should be corrected slowly and bicarbonate should be used judiciously and in a regulated manner. What is one exception to that?
I'm not sure, sir, but last time when we discussed, there was this one scenario where bicarbonate was used for correction, but I
Yeah.
don't remember it, sir.
Praveen,
No, sir.
Nitya,
Don't know, sir.
Tanya.
Even I'm not sure, sir.
See, in patients who have, for example, cardiac arrest, or patients who have prolonged, hypotension, where due to what happens is the significant the effect of acidosis, there will be depression of the heart. In this situation, you have to give bicarbonate rapidly and correct the acidosis so that once the acidosis is corrected, the heart will respond and start beating. That is why you see in patients whom you do ATLS, in the cardiac resuscitation, after giving couple of doses of adrenaline and things, they give bicarbonate because of that. And then in that situation, you will have to use bicarbonate in a rapid infusion or rapid injection. Otherwise, whatever Samir said is absolutely right. You have to correct acidosis slowly and use bicarbonate in a judicious manner. Okay, carry on, Samir.
Yes, sir. So uh, there is this tromethamine tris hydroxymethyl aminomethane, which is THAM, which is used as an alternative to bicarbonate. This is a biologically inert substance, and it limits the CO2 generation in the tissue, and it works at a better pH, which is 7.8, which is at our physiological range, and it has no venous irritation, and it can work in a closed system. This is much more preferred in patients with hyponatremia and cases of mixed acidosis and the ARDS, such situations. Then we go to hypothermia. So hypothermia has been hypothesized to be the double-edged sword, because it is beneficial and also has detrimental effects on the body. Beneficial effects, because hypothermia will decrease metabolism and cause vasoconstriction. There will be less loss of the heat, and the shock induced hypothermia is very different from the spontaneous hypothermia, which we see in patients who have been exposed to very low temperatures. The shock induced hypothermia has a mortality of 100% if the core temperature goes below 32 degrees Celsius, and there is 4 times more mortality if the temperature is below 35 degrees Celsius. Hypothermia induced mortality is due to the decreased ATP production And there is hypothermia causes enzyme inefficiency, and there is the platelet dysfunction, and aggregation of platelet will be low. There are studies which show that there will be 40% inefficiency of coagulation cascade, causing more coagulopathy in patients with hypothermia. So the outcome of hypothermia is the caloric effect, wherein uh, just to raise 1 degree Celsius, a lot of calories are needed. Calories are lost by the patient's body. Rewarming techniques which are used can be classified as either active or passive. So the active methods include the bare agas, installation of warm fluids intravenously. The method which is best of all will be the in intra gastric lavage of peritoneum, or even ECMO. uh, uh, mm, the active or passive methods, conduction and radiation among the methods are the best method of delivering heat to the patients. But radiation has technical challenges, and even the fluids which we give, warm fluids, they actually can't heat up the patient, because about 12.5 liters of fluids will be required just to increase temperature from 35 degrees centigrade to 36 degrees centigrade. But warm fluids are essential because they will prevent hypothermia. If we give like cold fluids, it will cause a hypothermia very fast, and which will be catastrophic.
Correct.
Finally, going to the coagulopathy. Coagulopathy in shock is multifactorial. It is due to acidosis, hypothermia, dilation coagulopathy, and also the genetic predisposition of patients. Usually, the evaluation of coagulopathy is done by the prothrombin time, partial thrombopoietin time, and the international normalized ratio. But there are studies which show that these tests are sometimes incorrect in determining the coagulation profile, because they are done at the snapshot in the time, and the patient's coagulation is actually in a dynamic state. So the thromboelastography has been suggested as a better modality. Um, so this is the thromboelastography. As you can see, it has components such as the R time. R time is the reaction time, and there is this alpha angle. The R time is the time until which the fibrin formation begins. The alpha will be the time where the fibrin formation and the cross linking will occur, and the K will be the dynamic time wherein the clot will occur at that time, and the maximum amplitude is the time where the strength of interaction between the coagulation factors, fibrin, and platelets occur. So, depending on this, we have the LY30, which is the lysis 30, and LY60, which is measured at 30 and 60 minutes, respectively. And depending on this, we can actually interpret the different coagulation defects and treat accordingly. So the treatment modality for the shocks which we have discussed.
Just
Yes,
sorry,
sir.
1 minute.
Yes, sir.
Nikita, so the work of triad which you described. So where do we use it in surgery now? what is the surgical, sort of, we should say, principle that we adapt in patients who have these things?
So we usually use it for PVD, sir.
Ravi?
Sir, in DVT patients.
Sir?
Hello?
Hello.
Hello?
Ma'am, are you there?
Yeah, sir is also there. But hello, sir.
Hello?
I think some network issue might be there.
Yes, sir left.
Wait for sir to log in. I think he might log back in, or somebody call him.
Yes, sir. Yes. Sir joined again, sir. Hello, sir.
Yeah, I think it got disconnected. Okay, carry on.
So it's
DVT, sir.
venous
Huh?
thromboembolism, DVTs.
Varicose triad.
Varicose triad. You didn't hear the whole thing. Varicose triad
Yes.
is used in damage control surgery. So whenever there is a major trauma, you follow the principle of damage control surgery, which you all know. Important thing is to stop the bleeding and resect the dead tissue and immobilize the bone. If at all the vessel is there, you repair it or you ligate it. Then take the patient to ICU and correct the hypothermia, coagulation defect, acidosis, and then do the definitive surgery. So the workout stride is very useful to, otherwise we lose the patient. Okay, carry on, Samir.
Yes, sir. So the treatment modality in which is very strongly influenced by the pathophysiology. As we see in hypovolemic shock, the clinical treatment will require immediate intravascular volume replacement by the standard wide bore peripheral venous access and rapid bleeding control, and the extent of blood loss which we saw in the ATLS table can be used for rough estimation. Surgical management should be undertaken as soon as possible using the damage control surgery approach, and the vasocon this inotrope support is needed if there is we are not able to reach a systolic arterial pressure of more than 90 of mercury, and those with uncontrolled bleeding accordingly should be given the transfusions of PRBC, FFP, and platelets in 1:1:1 ratio. And the multidisciplinary treatment will include early stabilization of coagulation by the coagulation factors, um, and treatment of any grave injuries like ruptured aortic aneurysm, and patients will also be stabilized using the permissive hypotension, which is systolic arterial pressure of 70 to 80 millimeters of mercury. Um, uh, and patients with large burns will will be indication of volume replacement will be done using the Brooks formula. Similarly, in septic shock, the administration of vasopressors are and in cases even inotropic drugs are needed. All sepsis patients, as soon as the samples are drawn, they should be given calculated broad spectrum antibiotics as soon as possible. In similarly, in anaphylactic shock patients, uh, uh, the reactions of arrhythmia, myocardial ischemia, and respiratory failure will manifest late. There are cases where they have been late as 12 hours after the initial event. So the anaphylactic shock is managed by administration of epinephrine and forced fluid replacement therapy, and also by the but second line treatment using the glucocorticoids and treatment of histamine using the histamine antagonist are also used. In case of neurogenic shock, uh, in addition to the fluid replacement, norepinephrine is given at increasing doses until the peripheral vascular resistance is rises. And then once the vascular tone is restored, direct or indirect acting sympathomimetic can be given. In obstructive shock, it will need the causal treatment. Um, According to the underlying cause of the obstruction, a pulmonary embolism can be treated using thrombolysis. Tension pneumothorax are relieved by the pericardial drainage accordingly. And finally, the cardiogenic shock. Cardiogenic shock, the invasive monitoring are the used for diagnosis, and the primary treatment will be as early as possible. We have to refocus in cases of acute coronary syndrome, and the surgical interventions such as pacemaker therapy and interventional ablation are should be underwent. Uh, the catecholamines such as dobutamine are preferred in case of cardiogenic shock, and also mechanical circulatory supports such as ECMO and the intra-aortic balloon counterpulsation are recommended in case of cardiogenic shock. Thank you.
Any questions? Hello?
No, sir.
No questions?
No, sir.
Okay. Comment from Nikita and then from either Nitya or Sanya.
Sir, his presentation has improved and the PPT is so nicely curated, sir.
Okay.
Like he spoke from the keywords from the PPT instead of reading it.
Okay.
Yes, sir, and he covered almost all the points.
Okay. Sanya or Nitya?
Sir, he
Same
did
here,
a
sir.
very good job, sir. He went into the depths of uh, physiology in shock, sir. That was very good, sir. Especially the thromboelastography and everything was more than Bailey. He
Okay. Good. Niranjan, your comments?
Sir, well presented, sir, and his presentation has
went in.
far improved, sir.
Okay, good. I
Yeah.
think I have to say, as far as I'll go as far as to say, this is the best presentation of shock I've heard for a long time. And I think Samir did a fantastic job. As Nitya and others said, the slides were very good and he was able to explain the slides well. and I think he went beyond the purview of just shock. And then the diaphragmatic representation was good. I think all in all, excellent presentation. Well done, Samir.
Sir, thank you, sir.
I think if there are no questions, Niranjan, thank you. Good night, all of you.
Thank you, sir. Thank you, sir. Good night.